The person that you are meeting when you come into an emergency room or you come in an ICU, how experienced are they? Because we are being left with the fact that as we train, they migrate. And as they migrate, we are not training enough to replace them as quick as they migrate. That is a bigger risk, a bigger threat to our health system than the lack of infrastructure. One of the things that I said multiple times to people during the pandemic is that ventilators don't ventilate people. And I think that I've said
You
that
said
to
it here.
you,
You said it
to
to me.
you. It doesn't matter how much money you have. And a lot of people found that out quite very easily. Money does not ventilate. Money does not transfuse. It may buy you some blood, but if you continue to bleed because you had an accident, it won't become blood.
After the COVID, how prepared are we for another mass pandemic or mass casualty?
So the first thing I would want to say, and to everybody who's listening, is that
Hello, Doc.
good morning, my brother.
Good morning. Good morning. Welcome to Diagnostics and Beyond, DAB.
Thank you very much. It's a pleasure joining you today.
You know, for me, you're one of the, I think, the unsung heroes during the COVID. And this takes me to a personal thing I also want to share. During COVID, we were frontline people in diagnostics, selling the face mask, the equipment, the pulse oximeters. So, you always believe you can't get sick, or because you are doing the work. And those days we had the badges. Everybody was in the house. We were the ones who were going around.
Yeah.
Until I myself came down with COVID. So I remember how I met you. So I was being transported. You know, those days when someone has COVID, the implications even on your family. So you don't want even people to know that you have gotten COVID,
Yeah.
because in Ghana, those days, if you hear that you have COVID, then it's like you are red, you are almost gone. So I remember on the transit from my house, from the hospital to the isolation center, they were always in constant contact with a team which I didn't know, because I was basically lying and I could hear they were telling them, check his oxygen concentration, what is happening, X, Y, Z. So when we arrived at the isolation center, I saw that at the Gan East, there was a particular place where you and a lot of doctors. So quickly, I was attended to and I was moved to a room. So for me, during my stay in the place for over 2 weeks, every day there was a chat where you were seeing countless people. So I was asking myself, how is he able to take it? Because the doctor seeing me will always say that he has sent some of the issues to Dr. Owoo and the team. You were on a chat, you had to discuss what was happening to him. So I am so happy that we have brought you to this diagnostics and beyond, like I continually say,
Yeah.
like I continually that, because people need to see Dr. O, who has saved countless lives. I say this with a lot of emotion, because I don't think I would be sitting here today, because during those dark hours, I didn't even want my kids or my family to get close to me, because I felt the facility where I was at, which was a normal facility, and they said I had COVID. All of a sudden, all the nurses and all the doctors quickly started stepping
Yeah.
aside. They just come to stand by the door. My wife was there. I was like, because they said, hey, this person has presented with COVID. So you were at the heart of the storm. You were not afraid of the COVID. The nurses were wearing your PPEs, but I felt that you gave some of us hope. From your perspective, how prepared are we as a country to handle such intensive care cases or such cases as COVID, which happened?
Yeah. So, first of all, the first thing I would say is, first of all, we give the glory to God for all the lives that were saved. And then I never worked alone, as you're very much aware. So, although I was the national coordinator for the severe and critical COVID-19 of the case management team. Even the case management team was a very big group led by Dr. Ali Samba and Professor Kaba. So even the ICU team in case management was like a team of brothers and sisters. I'm sure
Yes,
you
yes, yes.
experienced that. And it wasn't because they were not afraid, but it was a system that required a national response at that point. The work myself and other members of our team, which were full of unsung heroes who were there every day, not only in GAIS, the municipal hospital, Ghana Infectious Disease Center, or UGMC, but eventually multiple hospitals, Owoo, Rich Hospital, 37, and quickly we started springing up in almost basically every region in Ghana. And it was what I described earlier on as the global unpreparedness for a pandemic. None of us knew anything of this sort was going to happen. None of us, we've all complained about our health system before then, and it hit us. It hit us without giving us the allowance of time to even put our houses in order. And that is why majority of the people you met when you came to Gais had only gotten to know where Gais was just a few weeks before you got there yourself. So, for example, the team that I led from Kolebu Teaching Hospital, from the ICUs, were basically a team of about 65 people. Moved out of Kolebu, volunteered, not posted, basically said, we work in ICU. So, as I mentioned, I was head of ICU. My nursing lead for ICU and her team, we basically just moved ship because our ICU, although it was still required for managing a normal patient, normal in quote, as in they didn't have COVID, it was not structured to be able to be used for COVID isolation. So we moved with even pediatricians, our colleagues from the medical ICU, nurses from all over, medical lab scientists from Kolebu Teaching Hospital, respiratory therapists, uh, some of the biomedical engineers, and then just ask for permission from our hospital to pick a couple of ventilators from the hospital, and then drugs, equipment, and then when we set up. Now, those for me are the unsung heroes. I may have been at the forefront. I may have led most of the decision making and part of the decision that you saw being made while you were being transported. But that was because there was a coordinated team. But this was not pre-planned. We had to
No,
basically build it as we move forward.
this is very, very important. You know, we live in a country where I say that, from example, from when it rains in Ghana, I'm just using a simplifying device. When places get flooded, during the flooding, we always say, "Oh, our places are flooded. Are we going to get better?" Immediately the sun comes out, everyone forgets
Yeah.
and waits to the next rainy season. So it leads me to my question. After the COVID, how prepared are we for another mass pandemic or mass casualty? Like, if we were to hit, how prepared are we as a country?
So the first thing I would want to say, and to everybody who's listening, is that we learned massive lessons from that pandemic. And that's important lessons to learn. But learning lessons is not enough. If we learn lessons and we do not translate these lessons to change, then that is wasted knowledge. That is wasted lessons. But for me, more important is the lesson of preparedness of acute care. Has that translated in changing the face of acute care in our hospitals? There are more ICUs now than before COVID. There are more infrastructure that people have thought, okay, it is nice to have. I'm not sure there are more health workers that will be prepared to do that. In critical care, in ICU, infrastructure, equipment, logistics, diagnostics are very important, but so is human resource capacity. So we are training quite a good number of nurses, critical care doctors, but we have not been able to retain most of them in our country. As we sit now, I look more at solutions, not just on what's cry foul. One of the things that probably I can say is that we've gradually, in the last decade, wiped out the middle level of our health care system,
Wow.
the experienced middle level, so the specialists, the young specialists. And I mean, it is not any secret to anybody that our specialized nurses, specialized doctors, specialized pharmacists have left in droves in the last decade. What that means is that we can still have very beautiful hospitals, many of them. What that means is that you you're going to be having probably those of us who are growing old, and yes, I'm not that young, 23 years in health practice. Some people would be
Yes,
nearing
yes, yes,
retirement, isn't it?
yes.
Yes. Who may not have as much as energy as probably we had 5 years, 10 years down the line. At the top, teaching as many as we can, practicing as much as we can, but at the person that you are meeting when you come into an emergency room or you come in an ICU, how experienced are they? Because we are being left with the fact that as we train, they
They go.
migrate. And as they migrate, we are not training enough to replace them as quick as they migrate. That is a bigger risk, a bigger threat to our health system than the lack of infrastructure. It is beautiful for every region, every district to have a good quality hospital. But I can also say clearly that there are multiple hospitals that are unoccupied and unoperationalized. And the reason is not always because there are no equipment, but who are going to run them. One of the things that I said multiple times to people during the pandemic is that ventilators don't ventilate people. And I think
You
that I've
just
said
you
that
said it, yes, you said it
to
to me.
you.
Yes.
Ventilators don't ventilate people. People ventilate people. The meaning of that is that we're not in the age of robotics in our country. You're not going to have robots who are going to be running ventilators. It's people who are going to run those ventilators. The ventilators, you can bring 20 ventilators here now. If you don't have somebody who understands critical care, who knows what to do with the settings, who knows what to do when those feedbacks from the patient to the machine is coming. So it's not just, okay, I've set you up, tubated you, put you on a ventilator. That can be done easily by almost anybody. I can teach even medical students. I teach respiratory therapy students. I'm not talking about when they have become workers. How to intubate, how to put somebody on a ventilator. And that is level 200, level 300. But that is not critical care. Critical care actually means that you have an understanding of illness process, diagnostics, as we mentioned, and multidisciplinary can come together to make sure that you can move that person who has one, two, or three organ failure from this point to a point where you get him off that ventilator and getting him home. So that is where I am worried about. That, yes, we need to have a system that is intentionally looking at upkeeping our healthcare infrastructure and, for that matter, acute care infrastructure, emergency rooms, ICUs, high dependency units, operation theaters, and diagnostics that are related to them. But if we do not deal with the issue of our human resource, we would be worse off if we have another similar pandemic. I have less critical care nurses in all the ICUs that I have a supervision or I have a relationship over now than before the pandemic.
Wow, wow.
Those are specialized nurses. Those
Yeah.
are
It's
specialized
not every
doctors.
day, yes.
Everywhere wants them.
Yes.
So they're ready to pull them from you. So you have to have an intention and be very intentional about what is the system, what is the plan that is going to make sure that as we train these people, we replace them.
At the University of Ghana Simulation Center, I remember one of the meetings I had with you. You were doing something where you were training every health personnel,
That was just what I was about to talk to.
everybody in the University of Ghana, even the gate person, even the people who sweep, how to do CPR.
Yeah.
And for me, there are some of the deaths that we face in our part of the world which are so hurtful because it could have been averted. So from you coming from the ICU and actually moving, look at how busy you are. And I've seen firsthand where you are training countless people on a daily basis. What is the driving factor for that?
So I'll start from the selfish bit of it first. One of the days I asked my wife that if I were to collapse now, what will you do? Who will you call? And she got confused.
This
Not
has even continue. Before
because
you continue, because I'm looking left, I'm looking right, I'm asking ourselves that if we were to collapse, we know who will come. But yes,
yeah, and
yes.
that's why I asked that question. Um, I have fantastic colleagues, fantastic doctor friends, but for multiple of people who in whose circle or who I'm acquainted with, I will be their speed dial. I will be that phone call that they will make if they or their family
I'll
members
certainly do that.
would listen. And that played out in COVID. I made lots of friends and a lot of acquaintances from people if I never knew from anywhere. And then when they were calling my phone, it was somebody said, call Dr. Owoo. Now, so then I asked myself, and this question, the first time I asked myself was during COVID. Uh, as I got up one day, sat on my bed, and I said, so who would your family members call if it was you who is in ICU? And I got worried. I got worried because when I asked my wife, she got confused because she's for a long time had thought that, oh, if anything happens to anybody in our family, my husband does this. And she hadn't even thought that, okay. And since that time, my wife has been very particular about that. No, 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 you have to be careful because no, something that cannot happen to you. And I said, but I'm not God. So based on that, I said to myself, you can be as good as you uh, train yourself or work at becoming, but you cannot be your own doctor. You cannot be your own intensive care physician. You cannot be your own emergency physician. Uh, God forbid, if anything happened to you, somebody else would have to be competent enough for you. And you pray that that's somebody else who is the first person to touch you. And irrespective of where it happens, it's well trained, competent to treat you. The way I answered this question for myself was that it doesn't matter how much money you have, and a lot of people found that out quite very easily, that money does not ventilate. Money does not transfuse. It may buy you some blood, but if you continue to bleed because you had an accident, it won't become blood. So myself, a good number of colleagues that I talked about these collaborative groups are basically groups that are made up of globally known names in ICU care. Just step back and said, no, the biggest problem is not only in the ICU, it's actually outside the ICU. If 70% of the patients who are requiring critical care in the hospital where I work are in the general wards, what care are they receiving? Because the general wards are not built or structured to manage critical illness. The doctors, the nurses that work there are very intelligent people, but that is not their specialty. They are trained to look after people who are stable and to be able to determine whether those patients needs our team. So what we decided to do, therefore, was that we need to work at the preparedness, move the level of acute care awareness and intervention of every health clinical person from where it has originally or traditionally been to this point, because they are not all, those 70% are not going to get into the ICU, even in US, even in UK. It is, and we found that in COVID, immediately there was a surge. Some of the very high income countries had to ventilate people on football stadiums and things and corridors. So it's not a thing that is just us. So, and that is why in UGMC, for example, for a very from the very onset and very quickly, we decided that everybody who works in UGMC, doesn't matter whether you are permanent staff or subletted, or there's a secretary in the office or a doctor in the ICU, it is mandatory to be trained properly in basic life support and be certified. And we renew it every 2 years. Now, that gave us the initial platform. The one I hadn't told you is one part of what the decision we made based on the findings that came out. So myself and a good number of colleagues, Tim in Tanzania, Carl in Sweden, Bruce in South Africa, Leah in US, and then over 1,500 collaborators in the
Wow.
EECC network, they was decide that we need to develop a concept of what is called the essential emergency and critical care, which is a care that anybody who is critically ill should receive, the most basic care you should receive, irrespective of where you find yourself, even if it's a cheap compound.
Let me bring it to my everyday people who are eating fufu this today, who are trying to talk to their children. What signs should not be ignored at home that indicate that someone might need urgent care? Let's pivot to shift it a little
Yeah.
bit.
Okay, so first of all, I mean, we said the self-report by anybody is probably the most reliable lesson. So anybody who is complaining, I don't feel well, he may not even know what. One of the common things is you ask the person, why don't you feel well? They say, all over my body, my here, my there, my listen. But that complaint of I don't feel well always needs to be investigated. And it's better you investigate. I mean, my little son does that to me all the time. Oh, daddy, I don't feel well on the tummy. And sometimes, even at my level, I just tell the mother, oh, he's just pranking me. And the mother said, you always say that you must take it serious. And a number of the times, he's not pranking me. Anybody who's complaining of severe headache. I mean, we all get a bit of headache when we're tired, when we're exhausted. But somebody complaining of severe headache, complaining of feeling dizzy, anybody you see who's breathing is becoming fast. So in critical care, we say that the earliest and there's an earliest, most sensitive indication that somebody is becoming severely ill is they start breathing fast.
But Doc, we hit the streets. We hit the streets on one of our episodes, and people don't want to know. And people generally don't want to know. There are people who don't want to know. There are people who want to know. We've actually also brought a psychologist who's,
Yeah.
yes. From your point of view, and from all you are saying, I have someone asking us a question that their dad is 86 years. He never knew. And he told him that there's no need to know. At least I'm 86 years. I never knew I'm 86. What you don't know doesn't affect you. Do you think from that point of view and from your experience, do you need to know what is actually wrong with you?
So yes, I've heard people say what you don't know cannot harm you or cannot kill you, and actually that is not true. That is a significant fallacy, isn't it? Because if you don't know you are hypertensive, it does not stop you from getting stroke.
Exactly.
If you don't know you are diabetic, it does not stop you from having a complication that sends you into a diabetic coma. And that is why, if you remember, one of the things I said at the beginning is that to try to de-emphasize that those of us who work in critical care are necessarily the most important health professionals in the health system. One of the things I mentioned is preventive care. That's if we can prevent you from getting to us, for us, that is the best solution towards ICU care. And how do we prevent? It is by finding out early that I am fine or I'm not fine. Now, that is why we advise on routine checkups. There are conditions in men, in women, that we say that at this age, so for example, we do breast examination, teach women how to do self-breast examination. Why do we do that? Because if they can pick a mass in their breast early, and then that mass is found out to be a cancer, they may not suffer from it being terminal because it is picked up early. Similar for cervical cancer, which my wife did quite some work in during her master's program. We basically advise that women do pap smear or screening for cervical cancer from some certain age, and that age is actually in their teen age, and as they grow up. And the reason we talk about that is because there are vaccines for cervical cancer. So if you do not have cervical cancer, you can actually have the vaccine that prevents you from getting it because it's a sexually
So, Doc, which
transmitted
means
cancer.
you firmly, from all you are saying, which means you firmly believe that you should know.
Oh, you should know. You should know whether you have the medical condition or you do not have, because that is the only way you're going to be able. So it's not every medical condition that will kill you or that will even bring you to the ICU. Our relatives, our parents, a lot of them have hypertension. They are living into their 80s and older. Why? Because they are taking their medication. They are following the instructions they are given. But why are they able to? Yes, it's a bit of more cost for me and you when we buy those medication. But I would rather bear that cost than bear the cost of intensive care units or the cost of a stroke, the patient having stroke. And so they're able to follow the instructions that prevent that from worsening or reduce the rate at its worsening. Now, if you don't know, the risk with it is that the first time you are knowing, unless you die without knowing, and that has to be a very sudden death.
Yes.
If not, you will know. If that's what I said, for example, if you have a stroke and you did not die immediately from the stroke, you know that you have stroke. We will tell you eventually that you had stroke from either what we call bleeding in your brain or a blockage in vessel in your brain. You will know. But at that time you are knowing, it may actually be too late to do anything important about it. So no, it's not true that not knowing. The parts about, okay, let's not inform this person about this condition comes with maybe severe conditions. Yes, there are people who will find out that they have cancer and it is terminal cancer, that they're definitely going to die from it. And not only in cancer, but in a lot of chronic conditions and things like that. So there is a significant role for both the clinical psychologists, the palliative care team, the ethics team, that's a bioethics team that help in the care that we provide for this patient. So even how we give information is as important as the information.
Thank you very much, Doc. as you just speak, because I'm really, I'm a student and I'm really writing. You said something that there are vaccines for cervical cancer
Yeah.
prevention. Are they
Yeah, yeah.
in Ghana?
In Ghana. So there are a good. Oh, in most of our hospitals, you can easily have. So
No, because for me, this really struck a chord because my mom's younger sister, who, when I was growing up, she used to give me a lot of books to read. She died from cervical cancer, and I used to drive her to Kolebu a long time ago, and I could see the pain threshold she had was
that's
very,
crazy
very,
pain.
very, very, very high. So that's why when you mentioned cervical cancer, it really hit home that I should find out because there are countless women who could have actually, like you're saying, if there's a vaccine available to prevent it, who if they have something like that, they could actually yes.
Oh yes.
Without diagnostics, how is it possible to have an
It's almost impossible. That is part of the reason why critical care is much more expensive than most other medical interventions because obviously a good chunk of this comes with quite a cost. Uh, of course, the other aspects of that is that no diagnostic tool diagnoses people by itself. People have to actually be responsible for making those decisions as to what diagnostic tools they need to use and how to use them. So that is why even in the ICU, the attention to patients are not the same as you have in a general ward. The patients in ICU have doctors always there 24/7. There's no point in intensive care unit you do not have a doctor available. It is not an OPD hour or 8 to 5 or even 8 to 8. Even in the night, there are doctors. Nurses always, in most ICUs, the patients are so ill that we have one nurse to one patient. So you may have a 4-bed ICU that has more nurses than a 100-bed hospital that has not got an ICU. Wow. And that is the intensity of the care that is required. Monitoring is basically constant. So, in addition to having diagnostic tools, some of those diagnostic tools are actually monitoring observation tools, and they complement each other. So, whether they are laboratory investigations, whether they are radiologic imaging, whether they are it's an ultrasound, whether it is a blood gas, it is complemented by the intense observation, monitoring by the doctors, nurses, and other health workers that work with the patient. And the fact that these patients have continuous monitoring, whether it is their blood pressure or is their heart rate or is their oxygen level or temperature. So even the tools we use for monitoring patients in ICU tends to be a lot more complex than what we use in the general wards. And those are actually part of diagnostics.
wow. Ogasco, raise your body. Hey, Ogasco, raise your body. There. In fact, sleeping people are suffering.
Don't worry.
In fact, sleeping people, this one there's no brilliant science and math quiz woman to give them some bonus question. I am taking the risk. When he gets 70, I'll make it 7. You said that I intentionally gave him bad tiles, but the tiles were in front of him. Hey. Wow. I'm not wearing any belts, but yes. So that's 2, 3, 6, 7, 8. So you can see that the difference is clear as we continue.
No, 8 times 2.
Times 2
It's a double word.
Okay, 16. Hey, you see what I was telling them? I think if he
No,
jokes
don't
with me.
worry, don't worry. I know Gasco boys, they don't calculate.
You can see that now the scores is 77 for St. Augustine's and Dab, and then 24 for Dr. Owoo and Infancy. So thank you very much
Yeah,
once again,
thank
Dr.
you.
Owoo,
And
for
then
coming
thank you all
on
to
Diagnostics
our
and
audience and
yes,
then for
yes,
joining us on
yes,
this
yes.
beautiful
Wow.
day.
Thank you once again. Like we promised on Diagnostics and Beyond Dab, to only bring you very insightful, honest conversations. We are inviting you to subscribe. Subscription is free. So we see you on our next episode. This is Emmanuel Tekwabna Kenny, dabbing my way out of this episode. Thank you very much.
Thank you.
Thank you very much.